Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon to all of you. My name is Dr. Soumya Intadar and I'm working as Associate Professor of Medicine at King Edward Medical University. I'm also the Secretary General for Pakistan Society of Internal Medicine. I really feel delighted to welcome Honorable Chair, esteemed speakers, senior faculty members of Pakistan Society of Internal Medicine, and most importantly, the amazing audience, the attendees of this online PSIM Hypertension Course 2021. It's your presence that has led to such a successful, well-attended and well-received course, which is another achievement by Pakistan Society of Internal Medicine. PSIM Hypertension online course started 3 months ago and was attended by over 300 participants from all across the country. The course was designed in such a way to encompass all aspects of hypertension, engaging national and international faculty who shared their valuable insights and experiences, empowering all the attendees to address the menace of this silent killer, hypertension. We were lucky to have collaborations nationally as well as internationally for this course. We had collaboration with Pakistan Cardiac Society, Pakistan Hypertension League, ISH, which is the International Society of Hypertension, and World Hypertension League, and president of both ISH, World Hypertension League, Pakistan Hypertension League, and Pakistan Cardiac Society joined us in the different modules that we had over the past 3 months. Today is the last module or the last session of this online course, after which we will be concluding this. And today we have 2 talks by 2 brilliant speakers. One is the state-of-the-art lecture on hypertension 2021 and beyond by President Pakistan Society of Internal Medicine, Professor Javed Akram, and then the course director of this PSIM online hypertension course, Professor Azizur Rahman, who's also the senior vice president of Pakistan Society of Internal Medicine, will give you a take-home message or a summary of messages which is taken from all the talks which you have listened in the past 3 months. I think our chair for today's session is a little busy at the moment. He will join us shortly. Meanwhile, we will start our session and I would like to invite our first speaker for today. Our first speaker is a paragon of his profession. His knowledge compounded with his compassion to uplift medical education and health service delivery is unmatchable. He's a man who's an inspiration for every medical professional. He wears so many caps and we are still unable to decide which one suits him the most, as he is incredible in all of them. Be that of a physician, an academician, researcher, health manager, or a team leader. It's my great honor to invite today for the state-of-the-art lecture on hypertension, Professor Javed Akram, Vice Chancellor, University of Health Sciences and President, Pakistan Society of Internal Medicine. Dr. Javed Akram, please.
Bismillahirrahmanirrahim, and thank you so much, Soumya, for the introduction, which I'm sure I don't deserve, but anyhow, you are a family, so at least we should recognize each other if nobody else does. Thank you for doing so. And I'm very grateful to Aziz for asking me to play as a last man. Last men are always supposed to be game changers, either win or lose. But it's very difficult task coming after such good names, good speakers, even the legends, I'll say, in hypertension. And then to add anything, and that is why it took me so long to prepare this lecture. I've been, believe me, looking at the keenness and enthusiasm offered by the entire audience, and especially by the chief organizer, Professor Azizur Rahman. He was so keen, so meticulous, that motivated me to, put in so much effort and try to do whatever I could with the talk. So I'm very grateful once again to Aziz, and in recognition of his contribution to this course and many other things that he has done since the PSIM came into inception, we all agreed that he will be the chair of the steering committee for hypertension in the future on behalf of PSIM. That means he will be organizing all the CME activities, including this course, and collaboration with other societies, nationally or internationally, interested in hypertension and having joint session. And one of the joint sessions that Shabaz Qureshi is the director of that session has been arranged with PHL on during their forthcoming conference later on this month on Sunday. And again, Aziz and myself will be talking there in Karachi on this concluding session of PHL, Pakistan Hypertension D. We must try to collaborate as much as we can, and that is what PSIM will do under the leadership. So I'll be talking mainly about what I think is current approaches. There will be bias in my talk, because as you can see that I enjoy this title, FACC, Fellow American College of Cardiology, and I happen to be their regent for this part of the world, and also I have been part of their hypertension initiative. So that is why I'll talk more about what American College of Cardiology is doing about hypertension than JNC 8 or anything else, because I think American College of Cardiology remains itself current at all given times in whatever field in cardiovascular disease. We know that we are in the middle of cardiovascular disease crisis, and unfortunately, the predicted is that heart disease and strokes kill right now and will continue to kill the most people in worldwide. Right now, we know around 56 million deaths occur annually in the world, and out of them, 39 million deaths. That means the majority of the deaths are coming due to NCDs. And out of NCDs, 50% of these deaths are due to cardiovascular disease, mainly in the vascular bed of the heart or in the cerebral vascular bed. So high blood pressure, we think, kills as many people in the world annually as all the infections combined together. So as you can see, 9.4 million deaths are attributed just to high blood pressure globally. And the good thing, I think, is over here, after those alarming figures, that the percentage of deaths from cardiovascular disease that could be reduced by intervention, hypertension features #1. That means around 58% of the deaths attributed to hypertension can be avoided by effective control of blood pressure. While cholesterol control also contributes, and high sodium diet control, air pollution, tobacco, overweight. You see, the contribution reduction of cardiovascular mortality, hypertension is about 4 times as much as that of the tobacco smoking, but unfortunately underemphasized. First and foremost, the blood pressure measurement, we just take it for granted, and we doctors, including myself, we are very, very casual about it. This is an extremely important reading, and I think I cannot emphasize enough that the patient must be relaxed, sitting on a chair, and at least for more than 5 minutes, which doesn't happen in a busy clinic. So the best thing is you don't take a blood pressure. If you have an assistant, ask him to follow this protocol, and you just check it just to confirm it, or giving the confidence to the patient that you have also taken it, and you can then average it out. Ask the patients to avoid physical exertion, avoid caffeine or smoking for more than 30 minutes before measurement. Ensure that the bladder is empty. We see many times the patient says, well, I have to go to loo. We said, okay, don't worry, you'll waste my time. Please, now let me see you, and then you go to the loo. That will obviously jeopardize the measurement. We must not be talking to the patient, not taking the history at that time, must take off the clothing at the site of cuff placement and the site of auscultation, that is the radial artery. Sitting and lying. Remember, if you are doing it on lying, then you should do it on lying every time the patient comes to you. So you have to standardize it. Must use a validated blood pressure measurement device. We did a survey. We asked how often the physicians are calibrating, getting these equipment calibrated, and only 3% were saying that they were calibrating. Otherwise, 97% of physicians, whether they are general practitioner or consultants, they were not having it calibrated. If you are doing it on a sitting position, then the arm must be resting and not self-supported. Position middle of the cuff in the mid-arm, mid-sternum, and it should be at the level of the heart, especially the right atrium. Correct cuff size is very important. I do carry 3 cuff sizes on my patient couch, but I wonder if all of our physicians are doing it. Again, in that survey, we saw only 3-5% people do have access to the large cuff sizes in the obese, and that is by overestimation of blood pressure in the obese people. 80% of the arm must be covered, upper arm. Stethoscope, you can use diaphragm or bell, it is up to you, but you keep on using the same in everybody then. Make it a standard. First visit, you must record on both arms, and the higher arm should be taken as a reference, note it down and tell the patient that and usually in 80% of people, there is a difference in dominant and a non-dominant arm, but whichever is higher, tell the patient your blood pressure is higher in the right arm. Not to worry, it's something normal, but you must take that as your normogram. Take repeated measurements 1 to 2 minutes apart and then average them out. If you are, obviously we do palpatory method, and then for auscultatory method, above the systolic 30 millimeter, take the column and then deflate at not too quickly, please, because the artery tends to go in a reactive spasm. So it should be done roughly at the rate of 2 millimeter per second when you are hearing the cough sounds. The time of most recent medication must be recorded, and so the systolic and diastolic reading must be recorded, and patient must be told on the prescription what are the readings for his future reference. 2 readings on 2 KEN estimate, and as I said, the patient must be told in verbally and in writing. About the investigation, I do get chest X-ray done of everybody for various reasons, but it is not a standard PA view, because cardiac size, to some extent, the cardiopulmonary ratio is important, and also sometimes the notching on the ribs can give us a clue whether we are dealing with a coarctation of aorta here. Fasting blood sugar, and if that is equivocal, then we must go for HbA1c. Complete blood count, especially ESR, because we know arthritis of the small and large arteries can also cause problems. Polycythemia, anemia can be picked up. Lipid profile, because of the risk estimation 10-year. Cardiovascular risk estimation is important. Creatinine with eGFR. Sodium, high sodium will point towards Cone syndrome or aldosteronism. Low potassium will do so. Calcium is a very important ion, and we think usually people with hypertension, they have low calcium, and once you normalize their calcium, it acts as an anti-hypertensive intervention. Calcium is used in many studies as anti-hypertensive therapy. TSH is important, more anti-4, because both hypo and hyperthyroidism can cause hypertension. Urine analysis extremely important, especially the casts. for glomerulonephritis, red cells, and also sometimes urinary electrolytes are done to point out the underlying cause of hypertension. Electrocardiogram, although not a very sensitive index for left ventricular hypertrophy, but can pick up an old infarct or something by a baseline ECG is important to me. I always try to get echocardiogram because that is a wonderful thing to do. The reason is that that is the first test that will tell you when you are confused whether you are dealing with a normotensive patient with a white coat hypertension or hypertension which is difficult to diagnose, if there is a diastolic dysfunction or a systolic dysfunction, or if there is a left ventricular hypertrophy, which means rather than physiological, there are now structural damage to the heart because of the high blood pressure, irrespective of the readings. Even if the reading is 120 of 80, but the patient is having all these features on echocardiography, I would like to treat that patient because that reading is high for the patient. Because when we were medical students, we were told 140/90, do nothing, just a salt restriction and anti-anxiolytic. But now, of course, we know 140/90 is higher reading and we must do something about it. So echocardiogram is important and a very sensitive test, much more than ECG, to pick up early LVH. And also you can monitor that. If when you regress LVH, you can monitor. Uric acid is a very common comorbidity and tells you not to use interventions which will further increase uric acid. Rather use drugs like losartan, which is the only ARB which has a uricose-uric effect. Urinary albumin to creatinine ratio is also important from this point of view. So coming to the classification of hypertension, again, I think JNC 8 was a disappointment. That's why I am not discussing that. So we waited for so long, and it was nothing new that they came up with. So still we are using JNC 7, and we compare it with American College of Cardiology and AHA joint guideline. 120/80, everybody agrees, is a normal blood pressure. 120 to 129 systolic or below 80, that means pure systolic pre-hypertension. Obviously, we all agree if it's above that, still it is pre-hypertension as far as GNC 7 is concerned. While the ACC thinks it's called elevated blood pressure, and if the blood pressure is systolic blood pressure is above 130 or the diastolic pressure is above 80, it already qualifies to be stage 1 hypertension. No difference in 140 to 159 systolic or 90 to 99 diastolic. Stage 1 hypertension here in JNC 7 and stage 2 hypertension in ACC guidelines, which are more sensitive, which want people to intervene early and effectively at lower levels rather than the high levels. So the trend of ACC is to diagnose early and to intervene early. Above 160 systolic and above 100 stage 2 hypertension in both the guidelines, whether we are talking of GNC 7 or AHA, ACC joint guideline, here you can see. So important thing to us is out of office BP readings. Important, we must use greater use of this, and the greater use of this can be done with two tools. I use ambulatory blood pressure monitoring. I was probably the first one in the Asia to start studies on ambulatory blood pressure monitoring, even in 1998. However, home blood pressure monitoring has become popular, especially with validated machines like Omron for confirmation of office hypertension and for recognition of white coat and masked hypertension. Sustained hypertension, no issue at all. That means the home, out of office and office readings both are high, and that definitely requires therapy because they have very significant cardiovascular disease, morbidity and mortality. So that's no. White coat hypertension means that when patient comes to you in the office, it records unacceptably high readings, but out of office, the readings are normal. It is present in about 10 to 25% of adults with white coat with office reading, high office readings. That means 10 to 25% of people are unnecessarily treated if we are not conscious of it in the office. Cardiovascular risk profile is same as normotensive, but they have higher chances of developing hypertension later on in the life in many studies. They may not need treatment. It will depend upon the target organ involvement and target organ damage, like echocardiography. And also these people must be followed up for sustained hypertension as they have higher risk for that. People think, many doctors think, okay, एक दफा बढ़ गया blood pressure, second time लेंगे, third time लेंगे, white coat hypertension खत्म हो जाएगी. ऐसा नहीं होता. This is not a conditionable response. Patients, whenever patient will come to you, he will have the phenomenon of white coat hypertension. So it is not going to be conditioned whether you wait for 2 or 3, 4 times. So you have to have normal home blood pressure monitored readings or ambulatory monitoring reading where your 75 to 80% readings on ambulatory blood pressure must be normal. Masked hypertension is reverse of white coat hypertension, which means normal office readings, but higher readings at home and out of office or at work. And this occurs phenomenon again in 10 to 25% of adults. That means you will miss this hypertension if you have people who have normal, but they do have LVH, whether on echo or ECG, and they do have, when you look on their arteries through ophthalmoscope, and he's only 45 years old, but the arteries look like 70 years old, copper wiring, silver wiring, AV nipping, and the arteries are aging rapidly, then obviously you are dealing with high-risk cardiovascular profile, and this is because of the masked hypertension, and these people require identification and treatment to avoid further deterioration. Important, I think, is because we know that 5 to 7% of the hypertension is curable, and because it has an underlying cause, maybe in renal parenchymal, whether glomerulonephritis, acute glomerulonephritis, or some other kidney disease due to drugs or whatever. So remember renal parenchymal disease, where you see creatinine going up and albumin and creatinine ratios are deteriorating. Then renovascular disease. Now, in elderly, we know that in young, there can be congenital renal artery stenosis, and we can dilate the renal artery or intervene or put in a stent these days and get rid of it. But there is a time, if we fail to do it timely, then even if you intervene, even if you do nephrectomy on that side, people end up having hypertension because the damage has been done. This is the opposite kidney, the normal kidney is producing. So it does not necessarily mean when you diagnose it, you need a surgeon to come in. And the other thing, important thing in renal artery stenosis is that in elderly people with hypertension, they develop at about 10 to 15% of elderly people do develop at the age from 65 above with chronic hypertension. They do develop acquired renal artery stenosis. And sometimes when you hear the bruit and you ask for Doppler studies, you realize that they have renal artery stenosis, and it might be worthwhile during intervention or something like that in those people to get rid of the excessive renin being produced on the side where they have developed. If it is a bilateral renovascular stenosis, then it might be worthwhile considering putting in stents there. Primary aldosteronism is something underdiagnosed. We know that the potassium is low and the sodium is high and the other features are there. Obstructive sleep apnea, extremely common in people with obese people, but also can occur with people with normal BMI and normal waist circumstance. So please think about it because obstructive sleep apnea syndrome occurs in people who have more fat on the neck, whether they are overall obese or not, it does not matter. Non-steroidal and steroidal drugs can use and also hormonal use can lead to hypertension, we all know, and some of minoxidil and things like that can also be making the problem. Alcohol, fortunately in Pakistan, we are relatively, we don't see it that much, but unfortunately it is all over in the rest of the world and even in Pakistan to some extent. Pheochromocytoma and paraganglioma, important obviously to do VMA, HMMA levels and things like that, and 24-hour urinary collection. Cushing's syndrome or Cushing's disease, both Cushing's syndrome due to drugs or cancers or things like that, the increase in cortisol level, but the Cushing's disease also can produce this. Hyperthyroidism both can produce secondary hypertension. Aortic coarctation, undiagnosed or even after repairing, it does not mean if you repair aortic coarctation, the hypertension will go away, because if you do it very early, then it's possible if the diagnosis is made after 30 years of age, then usually they end up having hypertension. So it's important to counsel the patient that don't expect that the drugs, you will not require drugs, you might require drugs even afterwards. Primary hyperparathyroidism is a reasonably well-known entity causing hypertension, and it's important to diagnose it not only to correct hypertension, but also to correct the calcium metabolism pathway and things like that. Congenital adrenal hyperplasia must be kept in mind, especially in the teenagers with the features, physical feature. Mineralocorticoid excess syndromes other than primary aldosteronism seen with malignancies, seen with many endocrinopathies. Acromegaly, again, increase in growth hormones, and sometimes the people use growth hormones for various purposes in adults, and that can also lead to features of hypertension. Threshold for treatment, we know that threshold at any given blood pressure, if you have target organ involvement and if you have target organ damage, you must try to intervene irrespective of the readings, and that's my own approach. But as the systolic blood pressure goes up, as you can see, the absolute ischemic heart disease mortality very, very linearly go up at all ages, starting from 40 years and even from below 40 years, the curve is very, very steep, as you can see. And similarly, it is steep, not for that much as diastolic blood pressure beyond 75, but for anything above 75, we know that the diastolic pressure, there is, but we can argue whether there is a Jacob effect in hypertension or not. People can dispute it. I'm sure people will dispute it, and they should dispute it, especially after the Accord trial, which showed that lowering of the blood pressure for whatever reason beyond certainly level will bring in harm. But I sincerely believe, with my very limited experience as a student of hypertension, that there is no Jacob effect. To me, the lower the better, provided your patient is tolerating it, provided he has good sympathetic autonomic function, and provided he can protect, his system can protect the lower levels of blood pressure, we give the benefit to the patient. Here, blood pressure arteriosclerotic risk varies greatly at the same level of blood pressure. You can see that with higher blood pressure increase, arteriosclerotic, if you have systolic blood pressure from 110 to 130 millimeter, with low cardiovascular global risk, below 11%, you can see that there is very little increase in mortality. But people who have higher or intermediate global cardiovascular risk, who have hypercholesterolemia, obese, and diabetics and other comorbidities, you know, they rocket sky high. And the important thing is, this is very, very important, and this is meta-analysis of 51,000 patients in more than 26 randomized clinical trials. You can see that the risk reduction, the RR is constant once the cardiovascular risk is. But very important to realize, because when we are looking at hypertensive studies later on in this presentation, this will stand out if we understand this, that people with very, very low risk of arteriosclerotic cardiovascular risk below 11%, despite lowering of the blood pressure, their risk is going to be high because they have very low starting risk. Okay, so it's very difficult to separate these curves. And that is where ACCORD and advanced study and everything, that's the difference in these studies. But people who have very high cardiovascular risk of dying in next 10 years of more than 21%, they, once you lower their blood pressure, you can see that the risk reduction is very, very significant. So that is important, that what is the global atherosclerotic cardiovascular disease risk. Here again highlighting this at the expense of repetition. As your risk increases of 5 years cardiovascular disease risk in the percentage, if it is above 21%, you are very high risk. You decrease the blood pressure by 16 millimeter. Look at the number of events you avoid. Is the 70 events are avoided in 1,000 people treated. So you can see how much benefit you are getting there. While in low risk people, despite treatment, and despite having good reduction of blood pressure, the risk reduction remains very low because the starting risk is low. So that is important to understand that if you are wanting to, but that means that we should still be treating the people with low cardiovascular disease, because then they will not shift to high cardiovascular disease risk with time. So again, coming to ACC guideline, the systolic threshold for treatment, 120/80. Obviously, we must promote, we should not ignore it. We should not say normal hai, jo marzi karte phiro. No, we should say आप हायर साइड पे हैं, आपकी मेहरबानी, आपकी फैमिली हिस्ट्री भी है, आपकी लाइफ में एक्सरसाइज भी नहीं है, आप हर मोटे भी हैं, तो मेहरबानी करके अपना लाइफस्टाइल हेल्दी कर लें ताकि आपका आगे ब्लड प्रेशर से बचे रहें आप. तो if it is 120 over 120 to 129 systolic and more than 80 diastolic, then obviously non-pharmacological therapy must be initiated. That I'll talk to you, non-drug therapy in a while. 130 to 39 or 80 to 89 with no cardiovascular disease risk at 10 years, less than 10%, again, non-pharmacological therapy. While if the cardiovascular risk estimation is above 10% with the same blood pressure, then antihypertensive therapy must be initiated along with lifestyle modification. However, if your patient is diabetic or having chronic kidney disease with the same blood pressure 130/80, then again must initiate therapy at that stage. If the patient is above 65 and systolic blood pressure is 130 or more, that is isolated systolic hypertension, again must start therapy, initiate therapy. 140 over 90, one or both together, we must initiate therapy according to these guidelines. So what is our target? This, I think I'll just present sprint study because I love this study. Around 9,500 randomized people. Was originally, the study was planned for 6 years, but had to be stopped after about 4.5 years because of the overwhelming benefit that we got from intensive treatment as compared to standard treatment. Intensive treatment meant and this was NIH funded study, not studied supported by any pharmaceutical company. You can see that the intensive treatment, the lucky people got the goal blood pressure to 120. The unlucky one had a goal of 140. And there was randomized compared groups in all aspects. The usual protocol with the Omron, electronic oscillometer, readings averaged out and so much. As expected, the intensive group got the blood pressure lowering to 121 by 5 millimeter, and the standard group on the standard therapy around 134 by so significant difference between these after average. And here you can see that the study was prematurely stopped, rightly so, by DSMB, Data Safety and Monitoring Board, because of this slide. There was clear, after 1 year of these treatment in two groups, there was clear separation of the two curves. That is, primary outcomes were separated to, and after 4 years, we reached a statistically significant reduction in primary outcome, which was cardiovascular disease mortality, MI, non-MI, acute coronary syndrome, stroke, and heart failure, which are the main concern. So very significant reduction in intensive lowering. Death from any cause also was reduced in the intensive care group. Here you can see whichever aspect you look at the young or relatively old people, people with kidney disease, male, female, race, blacks, whites, or whatever, previous cardiovascular disease, systolic blood pressure, quantification, everything favors intensive treatment better than the standard treatment. Of course, this was published in the New England Journal of Medicine. Now, this is again a meta-analysis of 42 randomized clinical trials, excluding sprint, because sprint, if I bring in, it will be biased. Here you can see these studies were averaged out for blood pressure lowering to 120 to 124 millimeter systolic as compared to higher blood pressure. You see how much the favor hazard reduction was there. You can see the hazard ratio coming in favor of more lowering. 130 over 34 as compared to higher readings still, but not as much as lowering up to 120. You can see the 140 to 144 still there, but not as much. 150 to 154 still the hazard ratio in favor of lowering than more than going to 155 and above. But so important thing is that it highlights my point that I don't see any J-curve effect in any of these studies, except of course ACCORD. ACCORD is a very deceptive study, both from diabetes and hypertension, because they were elderly people, and the design was faulty, and there were so many other things, and it was also stopped prematurely because of the adverse outcomes. Here again, you can see the meta-analysis of 19 randomized controlled trial in major cardiovascular disease. The relative risk reduced by 19%, MI, 14%, strokes by 33%, and heart failure by 25%, with wide confidence intervals of 91%. So as you can see that we all agree that the target of 130 or below is important, desirable for prevention of MI, stroke, heart failure, and major cardiovascular disease outcome. Here you can see that if you are looking at targets of different reasons, the systolic 120 over 80 or 120 over 95, we do not have data, but we think this should be the data. If you have the reading of 130, 39 systolic and 80 to 89 with no cardiovascular risk, still you target it that the blood pressure should be below 130 by 80 with low cardiovascular risk. However, if the cardiovascular risk is high, we still we think this is high and we target it to lower it. If the patient has diabetes or chronic kidney disease, again we intervene at 130 over 80 and we try to lower it to one below. If the blood pressure at any stage is 140 systolic, or above 140 systolic or above 90 diastolic, then still we need to intervene to bring it to the target, which is 130 over 80. If the age is above 65 and only the systolic is above 130, that is enough to bring it down to below 130. So I think that's very, very clear. If we compare it with the ACC guidelines, because obviously, as I said, and I declared it in the beginning that I have bias for ACC guidelines, but the others are even more aggressive, especially the Australian ADA, because these are the consensus guidelines. So 130 over 80 in adult diabetic population. If you look at Canadian, they also are more aggressive than ACC. Adverse event, what stops us from being more aggressive at the end? This is important. There could be electrolyte abnormalities, there could be increase in potassium, especially in people with kidney disease, and there may be small decrease in EGFR. Now, whenever we start ACE inhibitors or ARBs in compromised people with creatinine, high creatinine, little bit or whatever, I tell them, देखो भाई आपका creatinine यूरिया बढ़ेगा. This doesn't mean आपका kidney function खराब हो रहा है. Please ये आपके benefit के लिए है. आप bear out करो, stabilize हो जाएगा. फिर patient करते हैं, वरना वो मेरे पास वापस आते हैं. अगर मैं ये नहीं करता तो दे से जी डॉक्टर साहब उसी दवाई की थी, मेरे किडनी खराब करते, ये करता वो करता. तो वो किसी और डॉक्टर को दिखाते हैं, उनको कहता है जी आप बंद कर दें. So the thing is, from my point of view, ACE inhibitors, ARBs, if indicated, can be used cautiously, even people with very poor GFR, provided you can monitor their potassium. That's the important thing. There is obviously, with the aggressive treatment, there is a very small risk of hospitalization, but biological and clinical implications are uncertain. So consensus all over the world, and especially with ACC, amongst the ACC, is very, very clear. The balance of benefits and adverse effects should never be equally weighed. Please, this is very, very important. Preventing cardiovascular events and death is more important than just adverse events. And that is the bottom line. Even when equally weighed, cost effectiveness analysis done by ACC clearly suggests that benefits outweighs adverse events by a substantial margin. So cost effectiveness at typical thresholds for value in healthcare and remain so even with substantially higher adverse events. So please accept the adverse events. Don't be afraid of it. If you are afraid of it, your patients are going to be afraid of it much more. Clinicians can manage, mitigate adverse events, but by modifying intensity of treatment or discontinuing or starting another treatment. Best proven non-pharmacological intervention, which is my interest, is weight loss. 10% body weight reduction is the target usually with caloric reduction. Remember, exercise से weight reduction कभी नहीं होता, diet reduction, diet से होता है. ये मैं मरीजों को हर रोज यही बताता हूँ कि fitness जरूर आती है exercise से, which is very good. So if you lose 1 kilogram of your weight, generally you lose 1 millimeter of your blood pressure, both systolic and diastolic. Hypertensives में अगर आप around 70% of the weight reduction करते हैं तो 5 millimeter blood pressure कम होता है. Normotensive बंदे में 2 to 3 millimeter कम होता है. DASH diet, nuts, legumes, rich in fruits, vegetables, and base of the pyramid पे जो चीजें हैं वो खाएंगे, saturated को छोड़ देंगे तो 11 millimeter कम होता है blood pressure वाले और 3 millimeter normotensive में. Sodium restriction, again significant 5 to 6 millimeter reduction in normal, you can see. High potassium and high calcium diet again reduces significant. Aerobic activity reduces the systolic blood pressure. If you are doing it 90 to 150 millimeter brisk walk, where heart rate goes to above 75% of basal heart rate, 8 millimeter reduction, and in normotensives 4 millimeter. Dynamic resistance, जो कि हम gym वाली exercises हैं, 4 millimeter over here and 5 millimeter in isometric resistance exercise, while normotensives भी benefit करते हैं. और ये exercise के बाद मेरी अपनी study है interval के against कि ये कम से कम आपका 5 to 7 hours blood pressure low रहता है. अगर आपने इसको definitive therapy लेना है तो that means exercising 3 times a day. So moderation in alcohol intake is important. And then again, my favorite subject, Saudi Medical Journal, 1992. I presented this study in Puerto Rico in Inter-American Society of Hypertension, where we use zikr and namaz as blood pressure lowering effect. After training by Professor Nawaz Anjum, our brother radiologist, and his good father, late father, may Allah bless him in heavens, once mild to moderate hypertension, but treated how to forget about your environment and just talking to Allah in namaz and zikr, your blood pressure goes down significantly, your heart rate goes down, and your catecholamine level goes down, and they remain low for 4 to 5 hours after namaz and zikr. So choice of drug at the end, compelling indication and non-compelling indication. Use in compelling indication, especially post-MI or silent ischemic heart disease, heart failure. Non-compelling, achieving good blood pressure is important. Lowering the number is important. It's not important with what drugs. Diuretic CCB is often a good choice. We think diuretic must be in a paradigm to achieve good blood pressure. And we love, at least I love thiazide type diuretics. And I again have a bias because I did about 4 studies with indapamide on the international level. I love indapamide because it's metabolically neutral. It has an antiplatelet effect and so on. That is why thiazide type diuretics, chlorthalidone, I don't use it that much. I use indapamide more. Calcium channel blockers, especially in the elderly. In the young, usually we start angiotensin converting enzyme. If it's not tolerable, ARBs. And if the patient has high uric acid, we use losartan rather than any other ARB. And now this is again my favorite subject, the surge, early morning surge. If you get up early, again, our studies of ambulatory blood pressure, and say your namaz and walk, you blunt it. But when you are doing the pharmacological therapy and the timing of the drug, the peak trough ratio, it's important to blunt that early morning surge, because most of the events, cardiovascular disease, cerebrovascular disease events, are occurring at that time because of the platelet aggregability is highest, cholesterol, triglyceride surge is highest from the liver, and also we know that vasoconstriction is more and growth hormone is highest, and we know cortisol is highest at that time. Here, blood pressure variability, we should be, this is an important aspect. If you look at groups with blood pressure variability, the higher the variability, the more the damage. So the drugs which we studied here in our studies, me and Shabazz Sarwar, and we did LVH regression studies and also blood pressure variability study. The best studies which decrease the blood pressure variability Our calcium channel blockers, especially amlodipine, was very, very good in low dose, which was, so it is the best results that we got of LVH regression was with ARBs and ACE inhibitors as compared to calcium channel blockers for the same degree of lowering of blood pressure. Again, this. So combination is required very early, especially in the blacks and with blood pressure systolic more than 20, then above 130, that means 150, or 10 diastolic, then you must start with 2. One of them should be an thiazide type diuretic, another one can be ACE inhibitor or ARB in a young person. In elderly above 65, it is good to start with one of the non-dihydropyridine calcium channel blocker. In kidney disease, we think the thiazide or thiazide type diuretics do not work very well after the GFR is below 50 ml. So you have to resort to loop diuretics maybe at that stage. Simultaneous use of ACE inhibitor ARB is not recommended and potentially harmful. One of the studies that we did, native study in Pakistan, a very large study of more than 3,500 patients done all over Pakistan in 19 centers. You can see whatever the background therapy was, the blood pressure was not controlled, ACE inhibitor, beta blocker, calcium channel, ARB, and amlodipine. Blood pressure was not controlled in around 89% of these subjects. We just added indapamide 1.5 milligram SR dose to them and look what happened. What happened, the normalization ratio was achieved to 92% and hefty 33%, 33 millimeter reduction in systolic and 19 millimeter after 3 months of therapy. So very important study to tell us that in Pakistanis, whether we are low renin or high renin doesn't matter, we still benefit from adding a thiazide or a thiazide type. Follow-up is very important. Compliance is extremely important, and that I cannot emphasize enough. Antihypertensive drugs in older adults, again, the important thing is what are the comorbidities and what is the limited life expectancy that we expect as a physician from if somebody is suffering from cancer, chronic kidney disease, end-stage renal disease, liver disease, then obviously we must be very, very careful and risks overweigh the benefits. Otherwise, in ambulatory people with good quality of life, we should be as aggressive as we can. Diabetes mellitus, we know ACE inhibitor, ARBs are better, especially if the albuminuria is there. They are better in heart failure. Again, non-dihydropyridine calcium channel blockers are not recommended, and guideline-mediated therapy is important, consisting of beta blockers. Remember, important is non-selective beta blockers, not cardioselective beta blockers like atenolol. Again, there is a couple of studies in the evidence I have. If high blood pressure persists, then prescribe ACE inhibitors, ARBs, and of course, combine alpha plus beta blocker drugs are also good enough. In ischemic heart disease, again, guideline-mediated medical therapy is important, consisting of non-selective beta blockers which are lipophilic, go to the brain because of the vagus effect of the beta blocker, ACE inhibitor, ARB, and of course, you can add diuretics, again, dihydropyridine, calcium channel blockers can be added, and so on. Reasonable to continue beta blockers on the long-term effect. People with good ejection fraction or low ejection fraction can be classified. People with kidney disease, I already told you that it depends upon the stage of kidney disease, whether stage 1, 2, or 3, depending upon the eGFR. Use of ARBs is little bit better because they are better tolerated from cough point of view in people with kidney disease. Strategies, obviously, it's a teamwork, telehealth, and patient and the relatives, family must be involved in the decision maker. And it's a team-based approach. Financial incentive to general practitioners, family physicians is very important. The more they diagnose, the more you give. And the UK, once it incentivized, because family physicians are part of the NIH in England. And when I was working there, they incentivize any blood pressure you diagnose, you get £7 reimbursement. And suddenly from 7% control rate, it went to 19% control rate within 5 years in UK. At the end, device-based therapy, very, very important. We thought it's a history now. But again, Radiance told us it's not history. People who are very difficult to control despite 4 drugs can benefit either from catheter-based renal denervation or alcohol renal denervation in the future. We'll see much more of it, or baroreflex activation therapy. And we are working right now with Meditronics to bring these devices to Pakistan. So very soon you'll see it, but in the interest of time, I'll not go in detail. Hypertensive, emergency and urgency, again, very, very important. One of the most important areas to go into. I'm sure that you already know it, but I only want to wish to emphasize that please do not give sublingual captopril or nifedipine drops, because I've seen more strokes with them, because these patients are living on the high blood pressure. Their arteries are used to that. Immediately you lower the blood pressure, they develop infarct. So blood pressure lowering in first hour should be no more than 25%, and it should be not more than target should be 160 over 100 in next 6 hours, and cautiously over 48 hours. So in summary, I'll say accurate blood pressure measurement to improve diagnosis and management of hypertension, more intensive blood pressure control than previously recommended to reduce the risk of cardiovascular disease and mortality, and employ strategies known to improve blood pressure control to all of us. Again, thank you so much to everybody for being here, and especially Aziz, especially Somia for such a good moderation. And I salute once again Azizur Rahman for the contribution. Thank you, sir.
Thank you very much, sir. Before I go on, am I audible? Because there was a slight distortion in the voice previously.
All good.
Okay, thank you very much. Thank you, sir. It is said that teaching is the act of sharing the knowledge that you have been given by others, with the hope that someday somebody, some way, will again be passing it on to others. So thank you for sharing your valuable experiences and worth of knowledge, and we hope that this is going to be very beneficial for all of the attendees. Ladies and gentlemen, our second speaker is the man behind the success of this online PSIM Hypertension Course 2021. He envisaged this course and executed it with such perfection that we all are impressed with it. It's his dedication and commitment at PSIM that keeps us all inspired and motivated. It's my proud privilege to introduce Professor Azizur Rahman, my teacher, a role model of medical professionals, a brilliant speaker, known to keep things simple, yet an effective communicator of knowledge. Currently, Professor Azizur Rahman is Professor of Medicine at Rashid Latif Medical and Dental College. Formerly, he has been the Professor of Medicine at Services Institute of Medical Sciences and King Edward Medical College. He is the course director of this online Hypertension Course 2021, Senior Vice President, Pakistan Society of Internal Medicine, and Editor-in-Chief of Journal of Pakistan Society of Internal Medicine. Over to Professor Azizur Rahman, who will summarize all the things which Professor Javed Akram told you in detail, but also give you the excerpts from the all previous talks in the last 3 months. So he has picked up the most important 4 messages from every talk, and he will be giving you a short summary and take-home messages from from this hypertension.
Soumya,
Over to Professor Aziz.
Soumya, you should have said that we are over the trailer and now the real movie coming.
Thank you.
Thank you very much, sir, for the kind words. I think after listening to your wonderful presentation, I realized two things. I think the entire course was perhaps not necessary, and my presentation is certainly not necessary at all. Since I have prepared it, and I can't hold it back, so I have to present it. And so thank you very much for the kind words, and you have given me so many blessings and kindnesses, and today you have given me another responsibility, and I pledge that I will give my full best. Whatever capability I have, it is all for PSIM. So today's presentation, as Soumya told you, that this is actually the summary. So unlike my usual style of emphasizing and elaborating and explaining, I will just go through these messages because they have already been discussed and there will be no questions because they have been covered completely. So I have taken them from all the speakers. So I'm presenting it on behalf of all the presenters. So my apologies if I have taken the message wrongly and duplicated wrongly. So I think we will correct it later. So just going through the presentation. All right. So the first message is from Major Journal Professor Muhammad Aslam. So messages will appear as they were presented, not in any other particular sequence. So he said, blood pressure homeostasis is carried out by multiple systems working in harmony. These include hypothalamus, autonomic nervous system, renin-angiotensin-aldosterone system, and kidneys. And he said all drugs are potential poisons, just emphasizing that there is something physiologically going wrong, which can be corrected by lifestyle changes. But we all accept that many times we cannot pinpoint the actual abnormality, so we have to go for medication. So I think in practice, medicines are blessing. And this message too by Professor Daniel T. Lackland, and he said hypertension is the biggest and modifiable killer of mankind. May cause ischemic heart disease, may cause cerebrovascular accidents, may cause chronic kidney disease, ending up with renal failure, and it may also result in premature death. Depending upon the cut points used, he said the worldwide prevalence may vary from as low as 15%, but may go up to 45% as different criteria are used and different populations are studied. Message 3 from Professor Munir Azhar Chaudhary, and he said blood pressure must be checked with calibrated apparatuses. And he also said that patient must be seated for 5 minutes. I think all these things were re-emphasized by Professor Javed Akram today also. So patient must be seated for 5 minutes, and he should be physically and mentally relaxed and should not have consumed any stimulant. Coffee, tea, we know, but these days we take these energizers and energy drinks. And the phase 5 Korokov sound should be used as indicator of diastolic blood pressure. And he also emphasized that all types of BP apparatuses are acceptable, whether it is mercury, aneroid, or digital, as long as it is in good physical condition and is calibrated. Then Professor George Sergio, his message was that digital BP apparatuses are preferred over mercury apparatuses. And he was very sure. Although in Pakistan, physicians, patients, and everybody is still not very comfortable about the accuracy or the proper results of digital apparatuses, perhaps because we do not use them properly. Because these apparatuses are very accurate, very sensitive, but not intelligent. So, and he gave us a list of validated apparatuses on this website, www.stridebp.org. This is actually his own organization. And this list is also available on British Hypertension Society and many other sites also. And I checked, as Professor Javed mentioned by name, the name of Omron, the brand available in Pakistan is included in that list. So those who use this Omron, I think they should feel assured that it is accurate. And he also said that ambulatory blood pressure monitoring has great role in determining the exact status of BP, particularly in white coat hypertension and masked hypertension. On my query, he said that he does it on every patient, but he practices in a hypertension specialist center. We may not be able to do it in every patient, but we can at least do it in those patients where we're not sure whether the patient has sustained hypertension or not. So these two categories, white coat hypertension and masked hypertension, I think we should do ambulatory blood pressure monitoring, or at least home blood pressure monitoring. So then this is my humble message. I was given the assignment of initial evaluation. Every patient with blood pressure may be actually different, and he needs to be evaluated regarding, first of all, to establish the diagnosis. Just one reading, high or low or normal, doesn't determine his status. So we have to measure his readings multiple times according to the method described by Professor Munir Azhar, and to determine if there is some hypertension mediated organ damage already. And I think I fully agree with Professor Javed Akram. I actually use echocardiography as my selling point. There are many patients, they believe that the blood pressure rise is just a temporary. Now, if you demonstrate that there is diastolic dysfunction or there's left ventricular hypertrophy, you can then convince the patient that the hypertension has been there for quite some time and end organ damage is already there. So we are already somewhat late. We cannot afford to lose and waste any further time. And to rule out secondary cause, although in only 5 to 10%, but if somebody has a secondary cause, there is a possibility of curing that patient. And to determine the comorbidities, and all the panelists and I think attendees by now know that many conditions, they determine our choice, like asthma, uremia, hyperuricemia, heart failure. So they determine. So I think patient needs to be described as a complete person, not just the blood pressure reading. And on the basis of all these, every patient deserves a designer and individual treatment plan. One pill may be absolutely great for one person, but may not be great for another person. So as a physician, it is our duty to choose the best for that person. Professor Solid Sadiq's message was blood pressure variability, minute to minute, day to day, and visit to visit, in addition to blood pressure readings, is an important factor in causing atherosclerotic cardiovascular disease. And he said that there was a study which showed worse BP variability in Pakistan. So that is something we should not feel proud about. And then he said blood pressure variability can be best addressed with amlodipine. Of course, all drugs have merit, but blood pressure variability, as he said, can be best addressed with amlodipine. Our friend Tariq Hussain, and his topic was cut points. He said hypertension is diagnosed when one of these conditions are met. Office readings, they are equal to or they exceed 140/90. Of course, we assume that these are correct readings, not taken hurriedly. So if readings are more than this, either of the one, either systolic more than 140 or diastolic more than 90, this will make him hypertensive. And home blood pressure monitoring readings are different. Now, please note down, my dear attendees, although we emphasize that home readings are more reliable and they correlate with cardiovascular disease more accurately, provided they're taken correctly. But you please note down that the cut point is different. Somebody having 140/90 at home is definitely hypertensive. I think 135/85, as Tariq said, is actually the cut point. In ambulatory blood pressure, so in ambulatory blood pressure, we can have 24-hour average, we could have night values, we can have day values. I just took one of them, 24-hour average, 130/80 or more will make somebody hypertensive. Now, in case of disconcordance, then I think we will take the higher values. It is, I think, better to treat somebody with antihypertensive, even if it is borderline or upper normal, then not to treat him if the bodily values are borderline. Isolated systolic hypertension is defined when systolic blood pressure is above 140, but diastolic is less than 90. It is the requirement that diastolic is less than 90, otherwise it will make simple hypertension. White coat hypertension when office readings are high and home readings are normal. And masked hypertension when office readings are normal and home readings are high. I will not go into the details because of the time. And he said the goal of the treatment is to bring it to less than 140 systolic and less than 90 diastolic, both of them, and lower the better in relatively younger people if the side effects of blood pressure medication is tolerated well. We all agree on that. And Fibha Sayed made a great presentation on lifestyle changes. She said lifestyle changes are recommended as first-line therapy for all patients with stage 1 hypertension without comorbidities. And I think Soumya also repeated the same message in her presentation. DASH diet, which is dietary advice to stop hypertension, regular exercises, and weight management are the mainstay of lifestyle changes. They should be started early and should be maintained. On every visit, you need to re-emphasize, to reinforce your message that they need to be continued because they will work only as long as they are done. And she said natural remedies like fish oil are not necessarily safe because there is no evidence. If something is natural, we can't assume that this is safe because some fatal toxins, poisons are also natural. Professor Muhammad Hafizullah Khan, he made a presentation of use of RAS blockers. He said RAS blockers, which are angiotensin converting enzyme inhibitors and angiotensin receptor blockers, are preferred agents due to their effect beyond controlling blood pressure, particularly in young people and those with diabetes, those with CKD, those with heart failure with reduced ejection fraction, and those who have suffered from stroke. So practically every patient. And he also said angiotensin converting enzyme inhibitors and ARBs have been tested in numerous studies and are found effective in cardiorenal protection because of their direct protective effect on the endothelium. Angioedema and cough may favor the latter, although otherwise they are equally effective. Some people still prefer ACE inhibitors. Some, because of the fear of angioedema, they prefer ARBs, but technically they are equivalent. Our friend from Faisalabad, Professor Amir Shaukat, made messages. His talk was role of non-RAS blocker. He said some of the non-RAS drugs have very useful role in some circumstances. And some of the circumstances he identified, amlodipine and thiazides are particularly useful in elderly. And methyl-ropa is very, very safe and effective in pregnancy. Beta blocker in people with sympathetic overactivity and also people with hypertension and ischemic heart disease and heart failure in reduced doses. Amlodipine in CKD3 and above. And these are some situations where non-RAS drugs are useful. Dr. Soumya Iqtidar, her topic was hypertension mediated organ damage in overview. And she said uncontrolled hypertension may lead to multiple hypertension-mediated organ damages, like stroke, like ischemic heart disease, like CKD, like aortic dissection, and visual impairment. And she said, all these complications are theoretically preventable. Like all accidents, all natural disasters are theoretically preventable. So like this, hypertension-mediated complications are theoretically preventable if we do our job well. Then she said, in patients with grade 1 hypertension without evidence of HMOD, antihypertensive agents should be recommended only if lifestyle interventions are insufficient to normalize BP in over 3 months. Because lifestyle changes not only are acceptable, are actually better way of treating blood pressure, only they work. Only if they work. If they don't work, then of course we have to resort to blood pressure medicine. Maybe I think on the first interview, you can judge if the patient is willing or keen or motivated to try lifestyle changes. If you can clearly see that this patient is not going to try even, I think it may be best to start with the medication. Thomas Unger, according to the criteria used, the prevalence of hypertension may be close to 50% in some studies, in some societies and groups. There's some actually repetition of the message because there was some repetition of the topics also. According to International Society of Hypertension Guidelines, if optimal care is not possible, optimal, of course, as the name says, is the best possible control, then in resource-constrained countries like low-income countries and low to middle-income countries like ourselves, one should contend with at least essential control. Not controlling, not treating would be a societal failure. So we need to offer something at least to those who cannot afford. For majority, treatment should be started with 2 drugs, single pill combination. This is a recommendation based on European Society studies and also International Society of Hypertension. I think Thomas Unger was one of the part of the International Society of Hypertension. Our most regular panelist and I think very, very keen partner of PSIM, Professor Shahbaz Qureshi, he said, guidelines must be implemented in letter and spirit. Follow the one which is easy to understand and is easy to follow. I guess that he pointed toward International Society of Hypertension Guidelines, and he may correct me today if I'm not correct. And goal should be less than 140 by 90, but no lower than 120 by 70. In fact, he said, whatever guidelines you use, whatever train you take, your destination should be to get blood pressure to less than 140 systolic and less than 90 diastolic. And he said, under less ideal situation, blood pressure must be lowered by at least 20 by 10 millimeter mercury with whatever agent available. That agent may not be listed as the most preferred in the guidelines. It may be in the down the list. It may be in the second tier, but whatever is available, use that and bring the blood pressure to less than 20 by 10 so that we can prevent the major complication. Professor Sajid Abella, and his topic was hypertensive emergencies and hypertensive urgencies. And he also gave us very clear and crisp messages. Hypertensive emergencies must be recognized and referred to the hospital for urgent BP lowering, because general perception about hypertension is that it should be taken casually, not casually, but on long term. But if patient has hypertensive urgency, he should be referred to the hospital. Morbidity and mortality may be substantially reduced by time election. Okay, and he gave the definition of emergencies and urgencies. I will not going to repeat them. And he also said that beware of over normalization. Mean arterial pressure must not be lowered by more than 25% within first hour after the diagnosis of antihypertensive emergency. And this can happen if you give sublingual captopril or amlodipine short acting, because then things are not exactly in your control. So I think hypertensive urgencies should be treated in the hospital setting by an intravenous infusion, because then things are in your control. Professor Bilal S. Muhyiddin, and again, very, very regular person who attended almost all the session and a big contributor in all the discussions. His topic was hypertension and CVD. The organ most hit by uncontrolled hypertension is the heart. Of course, in his experience, because he deals with heart, but we otherwise also believe that cardiovascular system, if you take heart and brain together as atherosclerotic, as a cardiovascular system, then of course, this is the most hit organ. And he said that at the time of diagnosis, 10 years atherosclerotic cardiovascular disease risk should be calculated using one of the many apps available. And he categorized in the 3 categories: the low risk, less than 10%. If the 10-year risk is less than 10%, it is low risk. If it is 10 to 20, it is moderate. And if it is more than 20, it is high risk. But this is an arbitrary division. Every patient deserves treatment, and you need to prevent atherosclerotic cardiovascular event in every patient. And he said a holistic approach should address not only just the blood pressure, but smoking, diabetes, dyslipidemia, and lifestyle changes along with BP if you really want to prevent atherosclerotic cardiovascular disease. Professor Neil Poulter, and his topic was the timing of the blood pressure medication. And he said adverse cardiovascular events are best predicted by nighttime systolic ambulatory blood pressure levels. Not that the daytime blood pressure is not important, but if you have to pick one reading, it is a nighttime reading detected through ambulatory blood pressure monitoring, which most correctly correlate with atherosclerotic cardiovascular disease. And he said BP medicines are best administered as once daily, irrespective of the time or mean. Not yet enough evidence in favor of routine nighttime dosing. He mentioned about a study which indicated that nighttime administration of drug would be more beneficial, but then he identified many flaws in the study. Another study is on the way. So he said, so far, we do not have any evidence about the timing, whatever time patient prefers. Normally, I think we try, most of us, they give blood pressure medication as first thing in the morning. So whatever patient prefers, we may continue to do that. Then Professor Ian Wilkinson, his topic was hypertension in pregnancy. Hypertension in pregnancy can be of three types: chronic hypertension, the usual hypertension patient and conceiving; gestational hypertension, which is the hypertension which develops during pregnancy and diagnosed after 20 weeks, because this is actually caused by hypertension; and then preeclampsia, any type of blood pressure with proteinuria. He said all patients preeclampsia, irrespective of their condition, they may look physically stable. All patients with preeclampsia need to be hospitalized, and treatment of choice is labetalol. Shock-acting nifedipine should not be used. And he said RAS blockers are contraindicated during pregnancy. I think we all know that. Then Professor Masood Sadek, his topic was blood pressure in children. In overweight children, the commonest cause of hypertension is essential hypertension. We all know this, and he re-emphasized, don't assume that if this is a child, it has to be a secondary hypertension. Although the chances of secondary hypertension in this group would be relatively higher as compared to adults. Three commonest secondary causes include glomerulonephritis, coarctation of aorta, and renal artery stenosis. The last two are curable, so they must be detected and offered cure. Then in the pediatric population, beta blockers are generally preferred over other agents. And this is his statement. I have personal my neutral in this, but this is, I'm quoting his statement. Dr. Siddha Lodhi, hypertension in eye. Hypertensive retinopathy is a marker of systemic vasculopathy and predicts other HMODs. So I think very, very important, just looking into the fundus not only tells you that there is retinopathy, you can predict that there is vasculopathy elsewhere. And studies have shown that if there is retinopathy, there is at least 50% chances that the patient would have nephropathy also. And hypertensive retinopathy is characterized by AV nicking, cellular wiring, exudate, and hemorrhages. And out of this, presence of cotton wool exudates predicts hypertension and intracranial, hypertensive intracranial hemorrhage. Professor Naeem Kusuri, his talk was on hypertension brain. He said uncontrolled hypertension can cause ischemic stroke, hemorrhagic stroke, or encephalopathy. These are the acute complications. It can also cause chronic brain disorders like dementia and Parkinson's disease. And he emphasized that too much and too fast lowering of blood pressure in acute stroke can be counterproductive. This was emphasized by Professor Javed Akram and Professor Sajid Obaidullah. And he said blood pressure around 180 and 110 is okay. There is no mistyping here. Let me clarify. This is the reading he quoted. In acute stroke, if you try to lower blood pressure too fast, that could actually cause more ischemic damage, irrespective of the type of stroke, whether it is intracranial hemorrhage or it is ischemic stroke. although this much blood pressure, the family is going to press on you, but you, I think, need to explain to them that we will bring down the blood pressure, but slowly. Professor Alta Shute from Australia, she said isolated systolic hypertension defined as systolic blood pressure more than 140, diastolic less than 90 is seen in both elderly as well as in young people. Normally, this kind of phenomenon is attributed to elderly because of atherosclerotic vessel disease, but she said that it is common in younger people also. Best treatment for isolated systolic hypertension is amlodipine and thiazides. Azazman Ahmed, nephrologist, I think his talk was hypertension and kidney. Kidneys plays a central role in blood pressure homeostasis. It can be a culprit as a cause or victim, the HMOD, as hypertension. And commonest causes of secondary hypertension are renal, renovascular disease, renal parenchymal disease, and polycystic kidney disease, any of those. Professor Imran Hassan Khan the topic was secondary hypertension, non-renal. The commonest endocrine cause of secondary hypertension is related to adrenal. So I think that is why I always say that a good ultrasound in hypertensive patient is very, very useful. So you see two commonest organs which could be related to hypertension, kidneys as well as adrenals. So, but all endocrine glands may be linked to secondary hypertension. This was, I think, mentioned by Professor Javed Akram also. Primary hyperaldosteronism is commoner than previously thought. This is very, very important. And this was also emphasized by another speaker, a foreign speaker, whose talk was primary hyperaldosteronism. So especially if the patient is not responding well to the treatment, we must consider primary hyperaldosteronism. Then Macy Tomaswitsky, and his topic was resistant hypertension. He said resistant hypertension is defined as blood pressure more than 140/90, despite adequate doses of 3 antihypertensive agents, and one of them must be a thiazide or a thiazide-like drug. All should be in adequate doses, and adequate dose is defined minimum 50% of the maximum recommended. Pseudo-hypertension due to non-adherence is commoner than true resistant hypertension. So I think we must always ensure adherence before we start working on how to manage this resistant hypertension. Hardy, Hannah, Shomoni, and all patients, especially with the resistant hypertension, should be tested for serum renin and aldosterone to pick up primary aldosteronism. And according to the data he presented, the prevalence of primary aldosteronism is approximately 20%. He said he does it in every patient, but we probably cannot afford. And he also said that he does not ask the patient to stop his medication. So even if patient is already on medication, he would straight away go for renin and aldosterone levels. The treatment of choice for primary aldosteronism is mineralocorticoid receptor agonists like spironolactone or eplerenone, because they actually control aldosterone, which is the culprit in this case. Professor Khurshid Khan, the topic was pheochromocytoma. Keep a high index of suspicion of pheochromocytoma in people presenting with headache, palpitation, and diaphoresis. And don't dismiss them as simple panic attacks. We know panic attacks are very common, but one of those patients may actually have pheochromocytoma. So you better keep high index of suspicion. Patients with pheochromocytoma should be operated for 3 reasons. It cures the blood pressure, and paroxysm of hypertension may actually prove fatal. And then 10% may be malignant. They, of course, need to be operated. And surgery should be backed by a medical team. Like all endocrine surgeries should be backed by a medical team. Dr. Umar Farooq, his talk was the device therapy. Device-based therapy for resistant hypertension is a promising new technique, but still at investigation level. And when renal artery denervation is done, it was possible to achieve blood pressure reduction of up to 30 by 20 millimeter mercury, and that was maintained for 3 years. Very good response. But then he also quoted other studies which did not show that good response. So I think this is still not, as Professor Javed Akram said, after initial enthusiasm, there was a loss of interest, but these devices are gaining interest again for at least resistant hypertension. Professor Jinhua Zhang, hypertension remains the commonest modifiable risk factor for CVD-related morbidity and mortality. And we should reach out to maximum number of people and implement WHO's heart technical package. This is the detail of what heart means. I will not be able to go into the detail. Professor Javed Akram just said, but I'm going to repeat, hypertension remains the most important public issue of the present time and is likely to remain so in the future as well. Despite awareness, despite our efforts, this is going to continue to be a challenge. Importantly, it is the most modifiable cause of global mortality and morbidity. Treatment of hypertension is very cost effective. And he also said, unfortunately, it remains unabated due to lack of control and lack of awareness at all levels, from patients to healthcare providers. So we should at least do our part. And PSIM, he said at other time, not in this presentation, PSIM is committed to provide the latest information to doctors to help them evidence-based medicine up now. With that, I'd like to thank few people. First of all, the attendees for making this possible. I think I was so heartened to see more than 225, I think 230 people. And this was the 15th session. I'm personally obliged to all the attendees for showing this keenness and interest to make this online course successful. And then I'm indebted to our leader, our chair, president, for giving us so much trust to carry on such activities. And at this stage, I think I'll also like to mention Professor Aftab Mohsen, who is like the backbone of PSIM, and he is also very, very supportive. Then my team, and the team included Professor Tariq Wasim, and he tends to take everything seriously when it comes to PSIM. And then Professor Sajid Abdullah, he contributed a lot, and Bilal S. Muhyiddin was a very, very great help, not only arranging foreign speakers and also having every discussion, a very, very lively discussion, and making a great presentation. And then our brilliant Somi Iqtidar, she was actually responsible for arranging maximum number of foreign speakers. If you think this program was successful because of the foreign speaker, then the whole of the credit goes to Somi Iqtidar. And she also made great presentation and great moderation. And then at the end, I would like to, the Kashyap was also in the team. And I'd like to thank you, ma'am, for not only for the logistic support, but I think whenever he asked anything fair, or maybe not that fair, I think he did it, whatever demand I made. And I think I'd like to mention that all the presenters, all the chairs and moderate, but specifically, I'd like to mention the name of Professor Shehbaz Qureshi. He was very, very active, not only during presentation, even behind scene. And I think his presence in the course made it actually really, really successful. Then IT team, I must mention 3 names, not in specific sequence. Ans, who is running this show, he did it flawlessly. Only in one session, there were some hiccups, and because he was not there, because he had to go to attend some funeral. And this program was run very successfully by Anas. And then Daniel, I have never met him, but he made all this e-flyers and the certificates and the posters and everything. I think whenever he called, I used to call him middle of night, usually post midnight. And immediately he used to respond. And then our own young secretary, Asif Hussain. I think these three people, they played pivotal role to make this program successful. And if I have to arrange another such program, I think I will be very, very keen to work with this team. And then at the end, ADCO Pharma, I think ADCO Pharma provided us unrestricted grant and the whole logistic support. And again, we're looking forward to work with them again. With that, I'd like to thank PSIM, and I'm ever proud to be part of PSIM. Thank you very much.
Thank you very much, sir. And PSIM is proud of you. Thank you, sir, for real bird's eye view of how, what, where, and when to tackle hypertension by taking different messages from all the presentations and quoting pearls of wisdom from nationally and internationally acclaimed faculty of online PSIM Hypertension Course 2021. Before I move on to the comments and feedback section, if there are any announcements that Professor Azizur Rahman wants to make about the ceremony, concluding ceremony, and about the Google Forms that we have sent out to the attendees, please do so.
All right. Thank you very much. I have to make three announcements. One is about the certificates. We have made a very, very careful list of those who have qualified for the certificates. And immediately after this course, immediately after this session, we will broadcast that list to all the attendees. Please go through the list and check your name and check your title. If your name is not there, most probably you did not attend the sessions as per our requirement. But if you think that you attended and your name is not there, please contact our secretary, office secretary, Asif Hussain. We will recheck and make the correction if necessary. And number two, this presentation, we are going to convert into Word format. And this was very keenly instructed by our president, Professor Javed Akram. He instructed me to convert this into a permanent document, and a digital form will be available online right away after this course, but we are going to convert into a nice booklet. And this will be with the endorsement of all the speakers. We will circulate it to all the speakers, have their endorsement, and then we will print it and will be available free of cost to all the attendees along with the certificates, and will also be available free of cost to whoever wants it. And it will be actually published as a supplement of Journal of Pakistan Society of Internal Medicine. And third announcement is that we were planning an in-person concluding ceremony on 11th, which is perhaps not possible because of the restrictions, but we will do it. And whenever possible, I think we will let you know when that will be possible. Thank you very much. These were the three announcements I had to make.
Thank you very much, sir. Now I would like to request some of the senior members of Pakistan Society of Internal Medicine and faculty of the course, along with the attendees, to share their feedback and if there are any suggestions.
So, Soumya, before you go that, please ask Professor Tariq Wasim. A lot of people have been asking about the ASCD course.
So we will announce it after the feedback. We have a session for it. So I would request all the people who want to comment or give any feedback or suggestions to be very concise and brief, because there is a limitation of time, and restrict themselves to from 1 to 2 minutes so that maximum people can share their experiences with us. I would start with Professor Shehbaz Qureshi, who's been a very regular attendee of the course and had been giving very valuable insights to us throughout the course. Professor Shehbaz Qureshi.
Thank you. Thank you very much, Dr. Soumya. I'm really very humbled at the comments of Professor Azizur Rahman. It has always been my endeavor to learn new things. And I think that this course was exceptionally well planned. It had all the ingredients of an international course. And the whole course actually had such a lot of knowledge for everybody. And when I saw today, there were about 234 attendees that spoke highly of the importance of the course and of how well it has been done. Today's presentations by Professor Javed Akram and Professor Azizur Rahman, I think they have all actually summed it up all. जावेद has जैसे कहना चाहिए ना कि दरिया को कूजे में बंद कर दिया, और एक और फ्रेज मैं यूज करने लगा हूँ कि हाथी को रिक्शा में बिठाने की कोशिश की है. He has actually covered the entire subject of hypertension, and the whole course has actually been summarized by him so well that it is for the attendees, and I think for myself, I can say that I have learned a lot from what he presented today. And Professor Azizur Rahman has been exceptional in his summarizing of the entire course. And this was so well done that I think it is really very good that he is going to publish a booklet on it, which will be very useful for the attendees who can then use it for their own practice, because hypertension, as Professor Javed has mentioned, and so many have said, is a modifiable condition. And with it, we can prevent morbidity and mortality. An important point which I want to make here is the recent study which has been presented at the European Society of Cardiology about the SALT study is very important. And I think the Pakistan Society of Internal Medicine can take it forward, where we can have a mixed salt of sodium and potassium, which will reduce the incidence of hypertension. It has been done in China. We can do it here. And I think with the leadership of Professor Javed Akram, it would be excellent that we have the study in Pakistan as well. And we are going to have a combined session of the Pakistan Hypertension League and Pakistan Society of Internal Medicine, as directed by Professor Javed Akram at the recent meeting, which will be held in Karachi, inshallah. And we'll have an hour's presentation there with 3-4 speakers. Plus, we'll have the chairpersons. Professor Javed has given me the guidelines, and we will, inshallah, have a good session there. So all of you are welcome to be there. Now, the last bit, what I want to say is that all good things actually come to an end. And this is one of the best sessions that I've been attending. And the reason why I have done so is because it was so full of knowledge. But that is what happens, that all things do come to an end. And I really thank Professor Azizur Rahman, Professor Javed, Professor Somia Iqtidar, Professor Aftab Mohsin, Professor Tariq Wasim. They have all put their maximum effort, and they have created actually a world-class course on hypertension. Thank you very much.
Thank you very much, Professor Shahbaz Qureshi. Next, I would like to request Professor Bilal Muhayyuddin. He has also been very active throughout the course and has been sharing his comments. So I would just request him to be very brief in his comments so that we can give time to 7-8 people who are already in the line raising their hands.
Assalamu alaikum. Professor Aziz Sahab, Javed Akram Sahab, Professor Tariq Wasim, you are all those people who, in front of whose desks I have stood as a young boy and as a young doctor and with my legs trembling. When you honor me, it's as if a dream is coming true. So I must especially thank you for your kindness and for your kind remarks. It is indeed a privilege to be part of this real August meeting and gathering together so many good people together. I just have 2 or 3 points that I would like us all to talk about whenever we get a chance on it. And probably Professor Shahbaz in his upcoming Hypertension League meeting may consider this as one of the discussions that where we are going wrong. Probably, sir, one thing that I've always felt strongly is that when we started off jokingly saying that beta blocker is a beta blocker, and such statements, and then cuffs and all of these things which we started imposing on our patients, this started becoming a reason why our patients stopped taking their medication, especially in the young. And thus we're having these issues. And then we do talk of the length of the life, that it helps, but we never sort of stress so much on the quality of life. And under current circumstances, especially the director from in the PSIM meeting, in the ESC meeting, it was especially also pointed out that now it is not just cardiology, it's cardiovascular and hypertension and such things which affect the brain, which leads to dementia and all those Alzheimer's kind of things. They are the things that need to also be targeted. Yes, we had these sessions, but I think we need to further highlight that it is not just the quality of life, but it is the quantity. It's not just the quantity of life; it's the quality of life that also helps a lot. Professor Javed Akram Saab, this is especially. I see a bandage on your hand. I hope you're okay, sir. So, might be a sprain kind of a thing. You must be doing your exercises with your weights or something like that.
I paid the price for being a coffee addict. So
he had a little argument with his wife this morning.
Oh God, not again.
So he burned his hand while making coffee.
my request to sir, especially to you and Aziz Saab and Tariq Wasim Saab and all of the teachers who are actually sitting down and making the syllabi of medicine for the young students who are coming up. So please note that hypertension occupies probably one lecture in the whole of the medical college, especially from the medicine side. We have just done about 26 lectures, and we are still know that a lot of subjects regarding hypertension are lacking. This is just an off-the-head kind of a thing. How about having a compulsory questions, a few compulsory questions that the students would know that they would be asked about? And this way, they would have to make an effort about 5 or 6 specific topics in medicine. Like they already know this question will be there. So they have to work on it. And not in an MCQ way, but in a different style. Because this way, short essay questions, 2 or 3 or these things, because this will make them, we will be assured that they will know. Simple fact, how do you take a blood pressure? It is most amazing. We preach and we practice totally different. So these things, I think we need to go forward. And Aziz Saab, I just add on one thing more. When Masood Sadiq Saab and his talks were all going on, it was not just the beta blockers. He also talked about lisinopril. So lisinopril is their medicine so far because, and long time back, one of the professors said that it's because our limitations in our patients, and this is the drug that we have sort of hitting with it. And of course, so in other words, they are doing it. But at the end, sir, I'd just like to repeat the statement of our all teacher, Professor Rauf Yusuf. One of the meetings that I had the honor of being there when he was saying things, and he said it in Urdu, so I'll try to be as verbatim as possible. कि तुम जो मर्जी कर लो, आखिर तुमने मर जाना है. और जो चीजें तुम लोग बोलते हो, ये इस तरह से बात नहीं चलती. So quality of life के ऊपर ज़्यादा जोर दो, quantity of life पे जोर ना दो. And that is, sir, what I would like everyone to sort of take home with us. And Soumya, as always, you are looking pretty, and thank you always for the office.
Thank you very much, sir. Now, next, I would like to request Professor Sajid Ibadullah, who's also the Vice President of Punjab Pakistan Society of Internal Medicine, for his comments.
Assalamu alaikum to all. Thank you so very much, Soumya, for asking me for my comments. First of all, I must congratulate Professor Azizur Rahman for conducting such a superb program that everybody is having got lot of information, and we all have learned a lot. I must repeat, we all have learned a lot, and still there is quest कि ये कुछ अरसा और चल जाता. Again, congratulations to Professor Azizur Rahman and all the team, including myself, who has contributed even slightest in promoting knowledge to the masses and promoting knowledge to the attendees. About today's lecture, one thing which was supporting me when once I asked and question to one of the speakers about the recording of blood pressure. So I was of the opinion, if you people recall, that when we are examining our patients on couch, so it is an easy task for us to record blood pressure while the patient is lying and we are examining him for at least 3, 4, 5 minutes. That at the end of your examination, you can record blood pressure either in right or left, whichever arm suits. After the first assessment, as Professor Javed Akram mentioned, that whichever arm is having a bit higher blood pressure, we should be checking blood pressure on that arm in future. But my humble suggestion at that point was that if we are in habit of examining our patient on couch, then probably it is an easier for us to record blood pressure on lying down, although I don't go against all the international studies and international recommendations that it should be recorded while sitting and your arm must be resting on a table. But probably we should be given this much liberty to all those people who are examining their patients in different ways. Those who are examining their patients while they are sitting along with them, they can check it while as is recommended internationally. And few people like me who examine their patients on couch, whatsoever symptom they have, so probably it will be convenient for them to check blood pressure on lying down as well. The subject is open to discussion, and we can reply this query anytime any of the senior professionals who are sitting in the here, they can also say something about it. But this is what my humble suggestion is. Before I conclude, again, I must congratulate Pakistan Society of Internal Medicine for disseminating such a beautiful piece of information for upgrading the knowledge and contributing in the management of hypertension, which is one of the most important cause of morbidity and mortality. Thank you so very much.
Thank you, sir. Next, I would like to request the heartthrob of PSIM, Professor Aftab Musa.
Thank you very much for letting me give the comments. The presentations throughout the course were excellent, especially the pinnacle was today's presentation by Professor Javed Akram. And to Professor Azizur Rahman, I can say, sir, the course was amazing, truly remarkable. And it was like pulling out a magic from the hat, and you have done it very successfully. Congratulations to you and your team. And thank you very much for this. And the last but not the least, I have to mention Mr. Kashif Riaz from ATCO. And the word unrestricted support is the word I really like. And we got tremendous support from ATCO, Mr. Kashif Riaz and his entire team. Congratulations, everyone. Congratulations, PSIM. And thank you very much. And good luck to Professor Tariq Wasim for future course. Thank you.
Thank you, sir. Next, I would like to request Professor Munir Azhar, who's the Vice President, South Punjab Pakistan Society of Internal Medicine, for his brief comments, please. Sir, unmute kar lijiye, please.
Thank you very much for asking me to comment on this whole dynamics. So I will just say two important things. Number one is that after attending this course of Professor Dr. Azizur Rahman, I would say that he has stood up as a great educationist, because everybody was most of the times talking about the contents. But I would say the way the things were taken up and ultimately concluded in the form of take-home messages, everything, these dynamics are, I think, very, very significant. And I would say that these are the benchmarks for all of us who are supposed to conduct or conclude any kind of programs in future. And I think these steps should be followed. And the dynamics were excellent, especially the regularity, punctuality, and everything. The contents were actually attributed. I congratulate and salute.
Thank you very much, sir. Next, I would like to request a very senior family physician from Doctor's Con. Dr. Altaf Seema, a very regular attendee of all our courses and has been giving very valuable input as well in our courses. Dr. Altaf Seema, please.
Thank you. Thank you so much, Soumya. On behalf of Pakistan Academy of Family Physicians, I'm grateful to hold the team, especially Professor Azizur Rahman, Professor Javed Akram, Dr. Soumya, and all the others who arranged this program. I think we are family physicians are the participants who benefited most from this program. Who benefited most from this program because we are the people, we are the physicians who are having first contact with a person, and it's our responsibility to diagnose and manage. And I think if the family physician is updated, he can manage most of the patients of hypertension and as well as diabetes efficiently. So we congratulate all the team on this excellent course. We benefited a lot, and I think more programs, more courses like this should be arranged, especially for family physicians. Thank you.
Thank you very much, sir. We consider all the family physicians part of Pakistan Society of Internal Medicine. I would now like to request another representative body of family physicians, Pakistan Academy of Family Physicians President, Dr. Tariq Mahmood Mia, to please share his comments. And thank you for encouraging your members to participate in this course.
I think I must congratulate Pakistan Society of Internal Medicine for arranging really a very excellent course for the family physicians. I must congratulate all the team, especially Professor Azizur Rahman. I know him from college life. He was my registrar and I was doing house job with him. And the way he was teaching at that time, I think he is an excellent teacher. And I know him that he was away from the politics, any medical or any politics. But being a senior vice president of Pakistan Society of Internal Medicine, I think he is doing wonders in academics again. So I must congratulate Dr. Soumya, Professor Javed Akram Saab, and all the members of your team. One thing I appreciate in this course, that there was a pre-test and then there was a post-test. And the presenter can see what is the enhancement in the knowledge of the audience in the post-test. Secondly, what the Professor Javed Akram has said, that in UK, the BP of the masses was not controlled because they cannot go so oftenly to a consultant because there is a lot of time consumed in getting the appointment. So when the NHS asked family physician to look after these patients and they gave incentive to the family physician, the control rate risen from 7 to 19%. That is remarkable. So at the end, I'll again congratulate you. I think the Pakistan Society of Internal Medicine is the only organization which has risen to the horizon in such a short time. And this is all of you dedicated office bearers and all the team. I must congratulate from my heart that really you deserve a lot. And I'll request you that please, the family physicians, there is no any arrangement from the government side for their continuing medical education. So the Pakistan Society of Internal Medicine, we can suggest you different courses for the family physician. And I think you will consider our request and will hold such an excellent program in future also, so that our poor masses to whom the family physicians are serving at their doorsteps, they can be benefited with the latest knowledge and with the latest guidelines. Thank you so much, and hats off to all of you. Thank you.
Thank you very much. This course would not have been possible without the relentless support of ADCO Pharmaceuticals, represented by Mr. Kashif Riaz. I would request him to give his comments, and please stay tuned, because after this we will be having comments from the audience, as well as Professor Tariq Wasim, Senior Vice President Research and Academics, will be announcing the ASCVD course after Mr. Kashif Riaz, please. Mr. Kashif Riaz.
थैंक यू डॉक्टर सोमिया। बस मैं सिर्फ तीन बातें करूंगा। सबसे पहले तो आई वुड लाइक टू थैंक स्पेशली प्रोफेसर अजीजुर रहमान, then Professor Javed Akram, as he is always with me as an elder brother, Professor Tariq Wasim, Professor Aftab Mohsin, Professor Sajid Abadullah, Munir Azhar Saab, Professor Bilal, Professor Shahbaz Qureshi, and all the others, and you as well, कि आप लोगों ने बहुत अच्छी तरह इस कोर्स को रन किया एंड आपके साथ साथ हमारा भी नाम हुआ। दूसरी चीज़ जो मैं रिक्वेस्ट करना चाहूँगा वो ये कि ऑब्वियसली ये कोर्स हम अब 1 साल के बाद ही रिपीट करेंगे, मगर बहुत सारी जगहों से, बहुत सारे शहरों से ये डिमांड है कि इस कोर्स के पैरेलल कोई 1 डे 2 डे या 3 डे सेशन इसकी कंटिन्यूएशन में किए जाएँ। तो ये मेरी रिक्वेस्ट है, एंड एडको विल ऑलवेज विद यू इफ़ यू वांट टू डू दिस। हम सिंध में, कराची में, मुल्तान में या इस्लामाबाद में, KPK में क्वार्टरली बेसिस पे अगर ऐसे कुछ सेशंस कर लें, तो जब तक हम अगले साल के कोर्स पे पहुंचेंगे तो हमारे कुछ स्मॉल सेशंस भी हो जाएंगे, जिससे हम और अपने फैमिली फिजिशियंस को और जूनियर डॉक्टर्स को एजुकेट कर सकते हैं। और आखिर में मैं अपने बिहाफ पर, ऑन बिहाफ ऑफ माय चेयरमैन मिस्टर सईद अल्लाहवाला एंड द MD मिस्टर आसिफ अब्दुल सत्तार and whole team of ADCO, I am committed to you that ADCO is always with PSIM for any kind of academic activity. Thank you very much.
Thank you.
Doctor सोमिया, अगर ये इस्लामाबाद में करना चाहें कोई प्रोग्राम तो मैं हाजिर हूँ, और हम एडको का वाकई दिल से शुक्रिया अदा करते हैं कि ये इतनी अच्छी लाइव स्ट्रीमिंग थी कि इसमें कोई डिस्टर्बेंस नहीं आती थी। थैंक यू वेरी मच एडको।
Thank you to the IT team, Anas and Daniel, who's been our designer for all the books as well, and our office secretary, Asif. Dr. Bushra from audience, quickly, if you want to share something. Can you please give mic access to Dr. Bushra, please?
Dr. Bushra, please unmute yourself.
Bushra, you need to unmute yourself.
Unmute and start your video also.
Okay, quickly, can I move on to Dr. Bakas Ahmed Jan, if he's here?
Same for Dr. Bakas, you need to unmute and start your video if you are there, so we may know. So, they are not, both of them don't appear to be there.
Okay, Mr. Amir, are you here? Noor Tariq, Dr. Zulfikar.
I would suggest take the names of all people, and then those who are there, for us to know they are there, they should start their video, and then we can unmute them.
Tariq, Dr. Zulfikar Ahmed, and Sayyid Raza. If anyone of you are here, share anything, please go ahead.
Sayyid Raza is there.
Sayyid Raza, you please start your video camera so that we can see you.
Sure.
So he will not be able to start his video. Mr. Sayyid Raza, please continue with the audio only.
If we can listen, please go on.
I can't
okay,
start my...
please ask your question.
Sorry. Hello.
Dr. Sayyid Raza, we cannot give you access of the camera because it is designed that way in the software, but we can hear you. Please go ahead with your comments.
I just want to include my remarks rather than asking a question. I'm sitting right now in UK. I've been working in NHS, and I've been into this seminar for quite some time, and I felt that it has actually finely tuned my management to blood pressure. And I just want to give an appreciation to the people who have been presenting. And the best thing I've heard that you're all going to summarize this in a nice booklet and going to give it to us. I just wanted to say thank you.
Thank you.
Thank you very much, Dr. Sayyid Raza. We really appreciate your kind response. Anybody else who wants to comment? from the audience?
Waqas Ahmed has unmuted himself. Waqas Ahmed, are you there?
Dr. Waqas Ahmed Jan?
I am Dr. Amir. It was a very helpful course and we enjoyed a lot.
Where are you joining from, Mr. Amir?
From Peshawar.
Thank you very much. Thank you. It's truly very, nice feeling to have a mix of healthcare professionals from all over the country and also from abroad. I know quite a few people who joined from UK, some from the Middle East as well. So it's very heartening to know that we've been able to contribute to knowledge of and upgradation of knowledge of these professionals. Thank you very much. We were delighted to have you on this course, and stay tuned for the next course, for which I would like to request Professor Tariq Wasim to make an announcement for our next upcoming course. This is the hot topic these days. Every day he's asking about it. And if he has any comments and suggestions about this hypertension. Professor Tariq Wasim.
Thank you, Soumya. And I'd request Aziz Saab to unshare his screen so that I can just share few of the things which I wanted to. Okay, so I'll first share my screen. Right. I hope my screen is shared now.
You're on, sir.
Yes.
Right. Okay. So stage is all set for what do we do next. We have had an excellent course, first on diabetes, 6 months long, Zaman Saab from the platform PSIM, from diabetes chapter, and we have an excellent course run by Professor Azizur Rahman Saab as a course director, and of course held by so many members. What we have been going on to is that we had a rather lengthy course, 6 months, diabetes, which was quite lengthy. And we thought that some people may lose interest, and we have a middle course, which was excellently attended by more than 200 plus, well, 250 plus participants each Sunday. Now we are going that this atherosclerotic cardiovascular disease, which is actually this what we have been talking about, diabetes and hypertension and cholesterol, and they all go hand in hand, and they are the one which unite or combine to give you a mortality as a result of heart attack, stroke, renal failure, and all that. Despite managements of these things, we still are losing our patients. We still are not able. We have made a lot of investments into big hospitals and tertiary care centers, but the things remain that we have to start at the grassroots level to stop these things from, say, initiating and then, of course, managing them as early as possible. So with that in mind, and keeping in continuation with what we have already come forward, we are starting with another course, which will be starting in 2nd of October. And in this, again, we are have a collaboration from World Heart Federation. Thank you, Shahbaz Qureshi Saab, for managing that. We have collaboration with Pakistan Cardiac Society, Hypertension League, Aspirin Foundation, and of course, our partners from ATCO Laboratories, who are, again, very generous to give an unrestricted support. So this is what we announce, that this Pakistan Society of Internal Medicine presents atherosclerotic cardiovascular disease prevention course, which is the aim is to reduce CVD burden, morbidity, and mortality through educating the primary care physicians as well as whosoever is taking care of these patients, whether it be internist, whether it be cardiologist, whether it be, everybody needs to. And we have changed the timing and we have changed the days because we have some reservation from some of the participants that on every Sunday they have to cut out time from their family time, and this would not be possible for many of them. And so we have taken the time on Saturdays, 2:30 to 4. It would be live on Zoom, Facebook, and YouTube. We have the very, say, learned organizing committee, and we have a very, say, set of faculty will be showing in a moment. And of course, it would be, you can scan this program details as well as registration from this, and ATCO people would be coming to you for starting the registration right after this course is over. This is, we are divided into some chapters. There are no lengthy lectures. It would be, first is we have to assess the cardiovascular risk of every individual who comes to us. And it would be the talk followed by a panelist who would be having 10 minutes each for highlighting an aspect of this risk assessment and and then there would be, of course, a panel discussion and a summary with each. Instead of, as Aziza was summarizing it at the end, we'll be summarizing our each lecture after the end of this presentation. So this would be our first chapter, risk assessment, our second chapter on lifestyle medicine. And of course, we have been, the learned faculty has consented to be part of it. Our third chapter would be on role of antiplatelets, conducted, not, very well known Professor Shahbaz Qureshi Saab, and of course, being discussed by the, I would say, stalwarts of medicine and cardiology. And our fourth would be dyslipidemias, again, and the final would be a state-of-the-art lectures by two presenters, international presenter. One is Dr. Azra Mahmood, who is a pioneer of preventive cardiology, presently working in Riyadh, Saudi Arabia, and we have in communication with Professor Fausto Pinto, who is the president of World Heart Federation, and we have, and of course, this all activity has to be supported by ATCO as usual, and we look forward to. I find it difficult to fit in the shoes or the bar set by Aziz Saab. And I hope that as a team, we worked earlier, and inshallah, we are going to get to great heights along with this course as well. And we expect participation from family physicians particularly, because I think this is, first of all, they are the one who coming across, and they probably should start identifying these people at a very earlier on when the risk is just started. So that's what I have to say. Looking forward to see you from 2nd of October onward, every Saturday, 2:30 to 4 p.m. And inshallah, I hope that family physician usually have a break time at that time, and they would be joining as they have been participating in this course on Sundays. Over to you, Somya.
And Tarisa, we will be maintaining punctuality as always.
Inshallah, inshallah.
It will be starting as on time at 2:30, inshallah.
Okay, thank you very much. With this, we come to the conclusion of today's meeting. Once again, I'm really thankful to all the panelists, speakers, chairs for being so gracious by attending this every Sunday, and to all the attendees for making it such a successful event. Just as I close today's meeting, you would be able to see this ASCVD announcement on our Facebook page. Just to make sure that you have it in your phone, in your laptop, please subscribe to our channel on YouTube, where you can find all the lectures of all the courses which are run by Pakistan Society of Internal Medicine, and you can avail knowledge free of cost. PSIM continues to survive for excellence in medical education and for mentoring young physicians. Be part of PSIM, get our membership. There's a very, very nominal fee for residents, but I encourage all the fellows to become lifetime members of Pakistan Society of Internal Medicine. We are coming up with a brilliant lineup of programs in this year with few courses, few updates in medicine seminars, webinars, and few workshops. So stay tuned to Pakistan Society of Internal Medicine. It was delight to be a moderator today. Thank you very much for being here, and Allah Hafiz.
Allah Hafiz.
Allah Hafiz. Allah Hafiz.
Allah Hafiz. Thank you.
Allah Hafiz, and thank you very much, everybody. Sir, thank you.
Thank you.
Are we getting together for the next meeting?
No, because the meeting is, the physical ceremony is cancelled. We'll have meeting some other time.
Perfect, sir. Take care. Allah Hafiz and Aziza, once again, Mashallah, sir. Allah Ta'ala Apu Salam.
Sir, thank you very much.
Congratulations. Everyone for kind words.
Thank you.
तारे साहब अपना बंद कर ले, आपकी प्रैक्टिस नजर आ रही है सारों को. तारे महमूद मियां साहब. अल्लाह हाफिज।
अच्छा मैं कैसे मुझे क्या
अल्लाह हाफिज।
तारीफ ये सब प्रैक्टिस कर रहे थे बैठ के साथ साथ।
ओके जी, सी यू
ओके सर, अल्लाह हाफिज सर, टेक केयर।
नेक्स्ट सैटरडे।
Thank you.
Inshallah.
Thank you.
Thank you.
Thank you very much. Allah Hafiz. Allah Hafiz.
Right.